Disorder of iron metabolism presented by the SchrDbb. We reference Chemical Pathology Lecture Note of University of Cape Town. So we continue with this tutorial on iron deficiency, iron deficiency as being the first disease. So iron deficiency, the high risk group of patients having iron deficiency is in the case of infancy, where you have rapid growth that imposes high usage of iron. You have also in the case of risk factor of iron deficiency, in case of females of reproductive age who have menstruation, is it clear? And then in the case of female in reproductive age with pregnancy, is it clear? Because the iron is going to be used still for the formation of red blood cells in the fetus. Now, non-high risk factor patients. So these are other patients who don't have a high risk factor but is still a risk factor for iron deficiency. We have occult blood loss, which is commonly seen as GI blood loss when you use aspirin and related drugs, when you have peptic ulcer disease, when you have tumor, and when you have hookworm infestation. Other causes, other risk factors of that iron deficiency can be other blood losses like urinary tract infection, blood donors. You have malabsorption due to small bowel disease or gastrectomy. Now, what are the effects of iron deficiency? The major effect of iron deficiency is going to be first anemia, which is going to be hypochromic and microcytic. You're going to have fatigue. You have lack of energy, which is due to anemia. You have epithelial changes, which is due to the epithelial changes is going to because the epithelial cells just use it uses iron for its metabolism. So the epithelial changes when you have iron deficiency consists of angular stomatitis, consists of glossitis, consists of dysphagia. Is it clear? And that dysphagia is going to be due to esophageal web and can be due to Plummer-Vinson syndrome. Plummer-Vinson syndrome is a syndrome associating ulcers at the level of the lips, ulcers at the level of the mouth, and we have also angular stomatitis. Now, another case is that pica, eating of bizarre non-nutritive substances. Is it clear? So iron deficiency can also be seen as a symptom of iron deficiency is that the patient like to eat pica. They like to eat ground bizarre substances which are non-nutritive. Now, example of some typical value of various iron parameters in iron deficiency. Now, these are the different values. You have the iron stores. It can be normal, iron depletion, or iron deficiency. So in iron depletion, the iron stores are going to be empty. In normal case, it's going to be full. In iron deficiency, still empty. Now the plasma ferritin level is going to be normal at 100. It's depleted at 20, but it's going to be deficient as less than. In iron deficiency is less than 10. And you can see the different values here. The major element we show iron deficiency is going to be the transferrin level and the percentage saturation. Is it clear? When the percentage saturation is less than 10%, is it clear? When the percentage saturation is less than 10% and the transferrin level, when the percentage saturation is less than 10% and there is very high level of transferrin, just know that this patient has iron deficiency. The plasma iron level is not very good in order for you to know that there is iron deficiency. Is it clear? Plasma iron level is not very good. So what is good is mostly these two. You have percentage saturation which is less than 10% and we have a very high transferrin level can tell you that there is iron deficiency. Because the plasma iron is not necessary to know that the iron deficient, because a patient may have low iron and he has a high plasma ferritin and a low transferrin level. Is it clear? In those type of patients, you need to know that what in this patient they have a chronic infection. It's a chronic inflammation somewhere that is making the iron in blood to reduce and being stored more. Is it clear? Now the red blood cell morphology in iron deficiency is going to be microcytic and hypochromic, and the plasma transferring receptors. Is it clear? The plasma transferring receptors are the receptors. It's going to increase in order to make sure that what the iron is going to enter the cells more. Is it clear? So in iron deficiency, the plasma transferring receptor is going to be high, just to tell you that what? Just to tell you that the cells are craving for iron and they want more iron. So the plasma transferring receptor is going to be increased. So what is the treatment of iron deficiency? You just do supplementation of iron to individual. Always look for the cause of that iron deficiency that you have seen above. You have to consider food fortification. Is it clear? Now, this is the oral iron therapy. You need to know that ferrous sulfate, gluconate, lactate, fumarate, and succinate are all work and are very cheap. The best absorption between meals. The best is absorption between meals. You should not take it. The food decreases the bowel availability of iron. The more you eat food, the lesser iron is going to be absorbed. Is it clear? So it's between meals that you take the iron supplement. Some patients may experience gastrointestinal irritation, in which case giving the iron polysaccharide complexes. Is it clear? So those are the cases. Now the other form, you need to know that when you give iron supplementation for about 1 week, is going to increase the hemoglobin level of blood of 1 gram per deciliter. Generally, you have to know it as such. Now, the parenteral iron usage, generally, parenteral iron usage is not preferred, is less preferred than oral iron. We only use parenteral iron usage in case of malabsorption syndrome. Is it clear? So iron dexian IV can also be used, and the rate of HB rise as the same as oral iron. So there is no particular preference from oral iron and parenteral iron. So it is used if oral iron is poorly tolerated or poorly absorbed. Is it clear? So now the next one is anemia. So the only advantage that the parenteral iron has over the oral iron is that it replenishes the iron stores more than the oral iron, but the rise of hemoglobin is going to be occurring at the same time. Now, anemia of chronic inflammation. So in anemia of chronic inflammation is going to resemble as such. They see that the plasma iron is going to be low in both iron deficiency anemia and anemia of chronic inflammation, but the transferrin level is going to be high in iron deficiency and low or normal in anemia of chronic inflammation. You see the percentage saturation of is a best indicator for low level of iron in blood than the plasma iron. Percent saturation is going to be both low in both of them. The plasma ferritin level is going to be low in iron deficiency, but it's going to be normal or high in anemia of chronic inflammation, as I have said. Now, in anemia of chronic inflammation, is going to be normochromic and normocytic anemia. It means that the patient do not lack iron. Is it clear? And then it's hypochromic and microcytic. The hepcidin is going to be low in case of iron deficiency, but the hepcidin is going to be high in case of anemia of chronic inflammation. Why? Because you say that hepcidin is a very good protein in order to prevent the iron reuptake by certain bacteria in the body. Is it clear? And now the soluble transferrin receptors are going to increase iron deficiency to just say that the cells of the body are craving of iron. So these receptors are going to increase while they are going to be normal in anemia of chronic inflammation. Now the next disease of iron disorders is going to be iron overload. You need to know that acute iron toxicity can result from injection of iron salt in overdose. Usually occur in children whose mother are on iron therapy. So iron is extremely corrosive to the gastrointestinal tract. It's going to act on the mucosal tissue and manifest as hematemesis and diarrhea. So when you take too much iron, you're going to have hematemesis and diarrhea. The patient may become hypovolemic because of fluid and blood loss. So the patient is going to lose its blood. See, because that is going to kill the enterocyte, very corrosive to the enterocyte. Is it clear? The erosion of the gastrointestinal tract allows the absorption of excessive quantities of the ingested iron, which is going to result to a systemic iron toxicity. So when you have iron toxicity, it starts with a local iron toxicity at the level of the enterocytes, where you are going to have hematemesis and diarrhea and blood leakage, which can cause fluid losses and also hypovolemia. Now, when there is the enterocyte damage, you are going to have excessive leakage now of iron now into the blood, and when iron now enter in the blood, it is going to result to systemic iron toxicity. Now, damage to many tissues is going to result from an iron-mediated oxygen-free radical regeneration. As we have already said, iron is very toxic in the body because it causes free radical to be formed. Is it clear? Now the transferrin become 100% saturated, and then there's excess iron that is loosely bound to the albumin and globulins. Normally iron is not supposed to bound at the albumin and globulin, but you have in this case iron is bound to albumin and globulins. Is it clear? And then the percentage saturation is going to be 100%. 100%. You have transferrin, so you have percentage saturation in this case is 100%. So this is just to show how iron toxicity is very bad for the body. What are the features of acute iron toxicity? You have damage. We first have damage to the gastrointestinal tract with vomiting, diarrhea, plus or minus blood. You have shock due to vasodilation and capillary damage. You have drowsiness progressing to coma. You have lactic acidosis due to interfering of mitochondrial respiration by iron. We have liver damage, and we have myocardial toxicity because of circulatory failure. Now, how do you treat an acute iron toxicity? As in all cases of overdose, the first step is to ensure the patency of airway and breathing and circulation is adequate. Is equal. You have to use IV fluid is often required in order to treat the hypovolemia in this patient. And since the activated charcoal do not bind with iron, various methods of gastric decontamination is going to be tried. You're going to try MAC, you're going to try gastric lavage, you try whole bowel irrigation. Is it clear? Now, with iron, you use the major antidote for iron is going to be defurosamide. Defurosamide is a major antidote of iron. Is what is going to chelate iron at the level of the blood. Is dexferosamine. So dexferosamine is a water-soluble organic compound which has a high affinity to iron and binds with 8 mg of iron for every 100 mg of dexferosamine. So either you use defurosamine or use desferosamine. All of them, they can be very useful. So the next is hereditary hemochromatosis. Now, hereditary hemochromatosis is another disorder. It's an idiopathic hemochromatosis. Here it is also called a bronze diabetes. So it's a genetic defect which is causing an inappropriate increase in iron absorption. Is it clear? So in this case, you have an inappropriate increase in iron absorption in the face of increased iron stores. So it's going to result to increased iron stores, and you have an inappropriate increase in iron in blood. So clinical expression by is highly variable. It's going to depend on the amount of iron that the patient takes in the diet. Is it clear? And it's potentiated by alcoholism. Alcoholism is going to increase the iron that is going to be in blood. What's the clinical feature? Since the patient is going to have high iron, and the high iron is going to damage the different cells that stores it. Is it clear? The major cells that stores iron are going to be the liver, the reticuloendothelial system, and also have the kidney. Is it clear? Which stores some form of iron. So since these cells are going to store it, you're going to have liver cirrhosis, and which is going to increase the risk of hepatocellular carcinoma. You have pigmentation, high melanin, because there is hemosiderin. You need to know that hemosiderin also stores iron at the level of epithelial tissue. So you are going to have high pigmentation. Is it clear? Now you have also cardiac failure, because the patient is going to have cardiomyopathy. You have diabetes mellitus. This form of diabetes mellitus is going to be called Bond's diabetes, because iron is going to bind at the level of the pancreas and result to destruction of the beta cell of the pancreas, resulting to a Bond's diabetes. You have hypogonadism due to pituitary dysfunction. You have arthritis, and you have susceptibility to infection. Now, the genes involved in hemochromatosis are shown in the table. You have the different forms of hemochromatosis. You have hemochromatosis type 1, which is adult form. You have hemochromatosis type 2A, which is juvenile form. Type 2B is juvenile form. Type 3, and we have type 4. These are the different genes which are involved. You can just pause and then you visualize. And these are the inheritance method. Most of them are autosomal recessive, except from type 4, hemochromatosis type 4, which is autosomal dominant. Is it clear? So those are the different things to visualize here. So with the different hemochromatosis types, you can just visualize. You can just put a pause and then you visualize the diagram. Now the next, you have to know that the iron parameters were in the case of hemochromatosis. You need to know that the plasma iron level is going to be increased. Total iron binding capacity, the transferrin level is going to be low. to tell you that there is high iron in blood. The saturation is also going to be very high, and the plasma ferritin is going to be very high to tell you that there is high storage in the body. And now, since the plasma ferritin is greater than the amount that was shown, there is a certain amount for plasma for ferritin overload. It can tell you that there is an iron overload in the body. So the site of iron storage in the parenchymal hepatocytes, we have definitive diagnosis by liver biopsy. So when you do liver biopsy and DNA analysis, the definitive diagnosis. What's the treatment? So the treatment in this case is that you have to do repeated phlebotomy, just like a patient that has a polycythemia. Is it clear? So you just need to do repeated phlebotomy to remove the iron continuously in the patient. You have weekly bleeding, about 500 mils for 2 years, with removal of 20 grams of iron. You have hepatic and cardiac function may improve. However, diabetes, hypogonadism, and arthritis are unchanged. Is it clear? Because these cells cannot regenerate. Screen, you have to screen other family member with the serum ferritin, the saturation, and the DNA analysis in order to find if those family members have an unexpressed disease. Now, you have African iron overload. So this is caused by excessive dietary intake of iron. You need to know that what the traditional beer drinkers of organized steel drum, and also people in our context like to eat too much meat. Is it clear? So all that is associated with African iron overload. Is it clear? And also, so this is going to result to iron deposition in corpuscle cell and the reticuloendothelial system. Is it clear? Like in transfusional celiosis, that is going to suggest a defect in erythroid iron recycling. So in this patient with African iron overload, you are going to have increased plasma ferritin, you have increased plasma iron, and the percentage of iron, plasma of saturation is going to be very high. So the treatment is just venipuncture. Now we have transfusional celiosis. So if you do repeated blood transfusion for intractable anemia, it's going to cause iron overload. Is it clear? As this is no pathway for excretion, there is no pathway for excretion of excess iron. You need to know that normal iron excretion is only by the GIT. There is no form of excretion of excess iron from the body. Is it clear? So this transfusional celiosis can be seen in thalassemia patient or even in sideroblastic anemia patient. Is it clear? In thalassemia patient where you have globin gene defect, or in sideroblastic anemia patient where you have defect of heme synthesis or marrow failure. Is it clear? You have reticuloendothelial macrophages become iron overloaded, and later other typical tissues like myocardiomyopathies may also result to disorder. Now the treatment, you need to know that what intensive chelator therapy like disfurosamide can be used in order to treat, and you also need to do venesection. Cannot be used because the primary problem of this patient is anemia. So you don't do venesection in this patient because the disorder comes because of blood transfusion. Is it clear? Now porphyria cutanea tarda is another disorder in iron metabolism. So porphyria cutanea tarda is a disorder of porphyrin metabolism that is caused by a combination of factors, one of which is iron overload. The treatment is venesection. Is it clear? And the best note is going to be seen on porphyrias. So from here we have seen with most of all the notes on chemical pathology. So say thanks for your kind attention, and please don't forget to like and subscribe for our channel, SchrDbb.